Good morning, all of you. Welcome to the CPD webinar series organized by Society for Health Research and Innovation. First, I would like to introduce you with the housekeeping rules. The webinar link will be available from 9 a.m. to 9:50 a.m. due to joining. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. These housekeeping rules are to improve and maintain the standards of the CPD programs conducted by Shri, and thank you for your strict adherence for the CPD regulations. You can ask questions at the end of the webinar. So if you have questions, please type it in the chat box. If you have very specific questions, you can email us on officially13@gmail.com. So today's topic is fluid for critically ill children. The guest speaker for today is Dr. Manjula Hewageegana, intensivist at Pediatric Cardiothoracic ICU, Led Ridgeway Hospital. Over to you, Dr. Manjula.
Thank you, Samira, for that kind introduction. I hope everyone can see me and hear me and can see my slides very clearly. So first of all, thank you very much for organizers for giving me this opportunity. And I guess I would I would manage to do justice to your selection of me for this lecture. So today's topic is fluids in critically ill children. And I think whether it is critically ill children, adults, and one of the very common interventions that we do in our day-to-day life is administration of fluids. But maybe after antibiotics, maybe even before antibiotics, this is something that we abuse significantly. So let's talk about fluids in critically ill children and then see uh, how exactly we should sort of prescribe fluids in these patients. So this is the outline of my lecture. I'll be discussing certain physics and physiology in the first few slides. Then we talk about prescribing fluids, and I will be basically explaining the prescription of fluids uh, based on the phases of critical illness. So critical illness has certain phases, and during these phases, of course, you have to change the prescription of the fluid, and critical illness, as you know, is not a fixed situation. So it's a very dynamic situation. So you need to change your management according to this dynamicity. And then, if the time permits, we will discuss very briefly about special situations where the things I mentioned in this in the first few slides will deviate, and then ultimately we will talk about key messages that you should have uh, at the end of this lecture. So let's start with my experience about fluid. Now, I entered the pediatric stream in 2002. And this is the era where we were actually giving a lot of fluid to our patients, and this is mainly because one of the uh, uh, adult physician, Rivers, uh, did some research, and then he developed a protocol called early goal directed therapy, where you were supposed to give fluid according to certain goals. So until you achieve these goals, you will sort of administer fluids. Now, during this era, additionally, and some of the Indian consultants came and did lectures to us, and they were very much pro fluid administratives. So they were basically asking to give fluid. So we actually considered all patients are fluid deficient. So whoever patient comes in, one of the initial interventions we made was giving fluid. So we gave a lot of fluid boluses, and we administered a lot of fluid during this period. And this is the period where a lot of dengue deaths occurred, because I think now I thinking back, I think we administered a lot of fluid in these patients, and that that is probably why the outcome was not good. Then, when I became a senior registrar, somewhere around 2006, I personally had doubts in the current fluid use, and I selected intensive care as my subspecialty. So I was in the medical intensive care unit, and I can remember, still remember, one of the medical officers who worked in Australia with his wife. I can't remember exactly why he was in Australia. He came back and learning that our outcome was poor in the medical ICU. One day he came in and look at our patients. So he has worked in the emergency department and one of the ICUs. They are not a pediatric ICU but a adult ICU. And he said, we are giving too much fluid. So initially we were actually not agreeing, but then I developed a lot of doubts during this period whether actually he is correct or not. So read a lot during this period and became little more restrictive in terms of fluid. Then in 2010 I went abroad and came back in 2011, and with the overseas learning, and at this point, at this time of the years, and there was what we call feast trial. I don't know whether you all have heard about feast trial. This is something that opened our eyes about giving fluid, and which revolutionized the fluid therapy in pediatric patients. This study was done in Africa, which involved many centers. And and of course, when the results came out of this trial, we started to think about fluid in an entirely different manner. Now, earlier we were at ease of giving fluid, but then after this trial and its results, we, not only us but worldwide, I think there was significant difference of how you approach fluid resuscitation and maintenance fluid in these critically ill children. So we became very conservative in terms of fluid after that. And then I became a senior consultant after a couple of years and learn to deviate from the protocols and the guidelines and tailor made my fluid therapy to the patients. So and also I developed this way of tailor making fluid therapy for a particular patient during various phases of illness as well. So on admission this, and then as the time goes on, it will be entirely different. And from 2019 onwards, when I became a lead consultant in the cardiothoracic ICU at LRH, I went ahead, and rather than prescribing fluid to achieve a certain vital parameter, I learned to target perfusion rather than the vital parameter. So in the vital parameter, in the sense, peripheral pulses, blood pressures, and the capillary refilling. So rather than that, I learned to target perfusion, and also learn different ways, because we had echo machines and ultrasound machines inside the ICU. Learn to change fluid and to assess fluid responsiveness, and to give fluid only in fluid responsive patients. So this is my involvement of fluid. So I have seen era where we were giving a lot of fluid, and an era where we are very much conservative about fluid, and in fact doubting whether we should give fluid, as we are even doing now. Okay, so we talk about nutrition, we eat different things, but what you need to understand is that uh, we are made of fluid. So in the fetus, 97% is fluid, but as an adult, approximately about 50 to 60% is fluid. Now, this fluid is distributed in what we call body fluid compartments. Now, we have two main body fluid compartments: extracellular fluid compartment and intracellular fluid compartment. Extracellular fluid compartment can be divided into intravascular compartment and interstitial compartment. As these figures show you, you can see that neonates has more extracellular fluid, whereas adult patients has more intracellular fluid. And when you sort of prescribe fluid, this difference also has to be taken into consideration. Right. So let's talk about certain definitions before we move into the lecture proper. Now, when we talk about fluid, one of the words that you encounter is osmolarity and osmolality. These two are not, these two are all talking about the same thing, but has different units. So, osmolarity is the number of osmoles of solutes per liter of solution, whereas osmolality is the number of osmoles of a solute per kilogram of solvent. So, almost the same thing, but it uses different units. Then the other important word that we use in terms of fluid therapy is effective osmoles. So what are effective osmoles? So effective osmoles are those substances which actually do not penetrate a membrane. So our body fluid compartments has membranes between them. So intravascular compartment has the endothelium. Cellular compartment has cell membranes. So effective osmoles are osmoles those cannot penetrate those barriers. So they will therefore be restricted to a particular compartment. So that is what we call, those are the effective osmoles. And effective osmoles will create a osmotic pressure in that particular compartment. And this is called tonicity. So, so the effective osmosis, when present in one compartment, will create a kind of a tonicity. So, tonicity is the one actually determines the fluid shift between the compartments. So, therefore, it is very important to know that whether this what is the tonicity of the particular IV fluid you are using. And according to the tonicity, you can classify IV fluids into three types: isotonic, which has the same tonicity as plasma; hypertonic, which has higher tonicity than plasma; and then hypotonic, which has uh, lower tonicity than plasma. So if you add hypertonic solution, what will happen is it has tonicity more than the plasma and the cellular compartment. So cell will leak fluid into this into the outside compartment, so it will shrink. So if you add hypotonic solution, an opposite will occur. So the fluid from the hypotonic solution will move inside the cell across this cell membrane, and the cell will swell, and there's a chance that it might burst. In say, for example, red cell might absorb water and lyse. Then isotonic solutions are the balanced solutions in terms of tonicity. So they are the ideal ones to be used in that context. Now, at this point, I want to highlight that tonicity is not the similar to osmolarity. They have different meanings. Sometimes increased tonicity, the hypertonic solution will have hypoosmolarity, but not always. Say, for example, 5% dextrose is isoosmolar. So osmolarity wise, it is almost similar to the plasma. But because dextrose can move across the cell membrane and from one compartment to the other compartment, it is not isotonic, it is hypotonic. So it is very important for you all to know what tonicity your IV fluids has. So let's look at some of the IV fluids that we use in the next slide, and then decide on whether they are hypertonic or isotonic or hypotonic. Before that, let's see, if you add hypotonic fluid, isotonic fluid, and hypertonic fluid, what effects they have on osmolarity as well as total body water, right? So here you can see this is a normal compartment. This is the osmolarity. So usual plasma osmolarity is 300. And so this is the intracellular compartment. This is of an adult. This is the intracellular compartment, and this is the extracellular compartment. So if you add an isotonic solution, of course you are adding it to extracellular compartment, because you will infuse it into the intravascular compartment, which is part of extracellular compartment. So what will happen is there won't be any changes in the osmolarity because it is isotonic, but then it will increase the uh, volume of the extracellular compartment. Of course, after a while, this will leak into intracellular compartment, but most of the time, it will remain inside the extracellular compartment. What when you add hypotonic solution? So when you add hypotonic solution, as you can see, tonicity or the osmolarity of the plasma goes down. Now you can see that. And then it might increase uh, the volume of the extracellular compartment to a certain extent, but its main effect is in the intracellular compartment. So it will increase the intracellular compartment significantly. But if you add hypertonic solution, exactly opposite things will happen. It will increase the osmolarity, and then it will increase the extracellular compartment, and not only that, it will decrease the intracellular compartment, because now the fluid starts to move from the intracellular compartment into the extracellular compartment. So this is what exactly adding of a certain types of fluid will do to our body water compartments. Now let's look at certain types of fluid that we use and their osmolarities and their relative osmolarities and the tonicity. So IV fluids basically can also classified as colloids, crystalloids, and balanced solutions. So colloids are ones that has low molecular weight particles which does not cross the cell membrane. So if you infuse them, these particles will remain inside the intravascular compartment, and they will sort of keep the water with them. So examples are dextran and albumin. Of course, the blood and the blood products are also colloids, but normally you are not supposed to use blood or blood products as a fluid substitute, although we use it. We are not supposed to do that. And then crystalloids. So crystalloids are electrolyte solutions. Example, isotonic saline. And then there is a lot of interest in these type of solutions, and these are called balanced solutions. Now, when you give saline, saline has chloride. So when you infuse chloride into the extracellular space, what happens is, now you know that our body fluid compartment has cations and anions. And major anions include bicarbonate and chloride. So in these compartments, if one anion increases, the other anion needs to go down. If one cation increases, the other cation is supposed to go down. So likewise, if bicarbonate increases, the chloride should go down. If chloride increases, the bicarbonate should go down. So in this context, if you are giving a lot of saline, then what will happen is it will increase the chloride, and then because this increment in the chloride, the bicarbonate will go down, and this will create a situation called hyperchloremic metabolic acidosis. So that's the downside of crystalloid solutions. It may lead to because these are electrolyte solutions, it may lead to electrolyte imbalances, and also it will lead to what I call hyperchloremic metabolic acidosis, which can has different effects on your patient. So to overcome this situation, a lot of research done in last couple of years, and they introduce what we call balanced solutions. So balanced solutions are solutions which actually does not change pH or electrolytes once infused. Now, classical example is plasma light. So these are usual fluids that we use, and as you can see, some of these are hyperosmolar, some of these are isoosmolar, some of these are hypotonic, and some of them are isotonic. But what I want you to highlight here is that some of the solutions may be isoosmolar or even hyperosmolar, but they may be hypotonic. So say, for example, as I told earlier in a previous slide, 5% dextrose is hyper isoosmolar. Now you can see its osmolarity is almost the same as the plasma, 278, so between the range. But it is hypotonic because it doesn't have any sodium. Normally, the tonicity is determined by the level of the sodium. Now, if you take half normal saline, here, half normal saline, it is hyperosmolar because its osmolarity is 432, but because its sodium content is 75, it is hypotonic. So, if you add N on 2 to your patient, significant proportion of this is going to leak into intracellular compartment, right? Then, if you use um, quarter normal saline, 0.18% saline. I'm not sure whether this is available nowadays. It is isosmolar. It has a osmolarity of 284, but it is extremely hypertonic, and you can see that the sodium level of it of this is extremely low. So if you use this, you might actually kill your patient because you are going to create hyponatremia, and your fluid will leak into intracellular compartment. Right. But look at the balanced solution. So balanced solution has the similar osmolarity and the similar kind of sodium, but they are not actually using chloride as the other electrolyte. So therefore they are isosmolar, isotonic, but will not create dysnatremias or electrolyte imbalances or non-anion gap or hyperchloremic metabolic acidosis that all these fluids are associated with. So don't use these solutions which are hypotonic in your day-to-day practice unless in special situations. We will be discussing certain situations where you might be using these solutions. All right. So when we talk about fluids for critically ill children, there are certain situations that you use them. Right. One is as a maintenance fluid. Next, as deficit correction. So some of your children might come in with a fluid deficit. So you need to, of course, correct this fluid deficit. And then they may be having ongoing losses. So you might be using fluid to cover these ongoing losses. So example, if the patient has diarrhea, or more commonly, you will be using to resuscitate a patient. So these are the basic indications to use intravenous fluid, right? So I will not actually talk about deficit correction or ongoing losses, but I will concentrate this lecture on maintenance and resuscitation. So when we talk about a critically ill child, these critically ill children has different phases during their critical illness. Now, these has different explanations and different names, but I use this what we call ROSE concept, ROSE concept, which we can actually use in uh, fluid therapy as well. So R represents resuscitation, O represents optimization, S represents stabilization, and E represents evacuation, right? So whenever a patient comes in first, you might have to resuscitate that patient. Then you might have to optimize your fluid. Then you might have to stabilize your fluid treatment. And then, of course, you might have to evacuate some of the fluid that you have given during the initial phases, right? As you can see, this is the fluid. This is the fluid volume, these phases. Now, as you can see, during the resuscitation period and the stabilization and the optimization period, you have given a lot of fluid. So the fluid volume will be somewhere there. But then, of course, you might have to take this excess fluid out if it doesn't happen spontaneously. And by the end of evacuation phase or the third heat period, your patient is euvolemic. Sometimes you might have to do this actively. Right. So let's continue this lecture using a case. Now we are talking about a 6-month-old child who admits with a febrile illness, and this child looks very ill and has features of sepsis. So these are the clinical parameters. So child has a heart rate of 180. This is a 6-month-old child. Systolic blood pressure is around 60, which is low. Diastolic blood pressure 35, again a little on the lower side. And this patient is tachypnic and has a saturation of 97% while on 10 liters of oxygen per minute. So as you can see, this child is in septic sepsis, and not only sepsis, but this child is in septic shock. So what sort of fluid you will use, how much you will use, and what rate and at what rate you will be using this fluid. Now, if you think about the phases I explained earlier, which phase this child is in? Okay, so I think everyone will agree that this child is in the first phase, and this first phase is the resuscitation phase. And in intensive care point of view, we call this ebb phase, right? So this is where the first hit occurs. Um, and during this period, we need to administer fluid, and the goal of administering fluid is to revert shock and optimize the circulation. So when we talk about circulation, there are two circulations: macro circulation, and this is what you see or what you feel. Your vital parameters are actually things that show you how the macro circulation work. And then there is a thing called microcirculation. So microcirculation actually is the one that perfuse the organs. So you can have good number, you can have good blood pressures, you can have good pulse volume, but still your organs might not perfuse. So microcirculation is the one that indicates how good your organs and the tissues are perfused. And there are certain indicators of it and of this, and uh, the the most easiest way of seeing whether your microcirculation is functioning well or not is by looking at venous saturations and the lactate. So we will talk about it at a later stage. Um, so what sort of solutions you use? Balanced solutions or crystalloid solutions? And then how rapidly you will give fluid? So those are the questions that we need to answer. And this phase, with apologies to our nephrology colleagues, we call it reverse nephrology phase. We call it reverse nephrology phase because, as you know, that the nephrologists are mainly interested in taking fluid out. But at this phase, we do exactly the opposite. We give a lot of fluid. So that's why we call it reverse nephrology phase. So how much fluid we are supposed to give? So as per the latest guideline, we are supposed to give about 20 per kg fluid. And you might give this until evidence of fluid overload or no response is evident. And this is usually about 60 ml per kg. But we should be very cautious whenever you are giving fluid more than 40 mils per kg, especially whenever there is no ICU bed is available, or ICU bed is available, but the ICU is not capable of providing adequate respiratory care in case that is needed. So this caution actually came after the trial that I mentioned, the FEAST trial. So the current guidelines is very uh, particular about this statement, and they are highlighting this statement. And whenever you're infusing fluid more than 40 ml per kg, always think about whether the ICU bed is available or not, because more often than not, when you are giving more than 40 ml per kg, they might need some sort of a secondary respiratory support. So what type of fluid you should use? Of course, it should be isotonic. Don't use any hypertonic fluid as fluid boluses, because hypertonic fluid leak into intracellular compartment very quickly. So you might not retain uh, um, the resuscitated patient for a long period of time. So always use isotonic solution when you are resuscitating. If you have, now there are increasing evidence that the balanced or buffered solutions are better than isotonic solution, although these are not completely conclusive. but there are increased amount of evidence that these are much better than isotonic solutions. So if you have balanced solutions or buffered solutions, uh, use them. Albumin should not be used routinely. So it is not superior to any of these products. And on top of that, it is expensive. But in certain situations, you might use albumin as the first one. Say, for example, post cardiac surgical patients. There are some studies where albumin was a bit superior than the isotonic or the buffer solutions, isotonic solution rather, in that sort of circumstances. And starch, we hardly use. Don't use heta starch or related substances for fluid boluses unless in very specific situations, because resuscitation with starch is very much associated with acute kidney injury. So in sepsis, uh, during fluid resuscitation, don't use starch. And at what rate? As quickly as possible is the answer. Usually this is over about 5 to 10 minutes, but all is will depend on what sort of IV access you have. Um, and if you are resuscitating a patient who is at risk of fluid overload, say for example, it's a patient who is in heart failure as well, or it's a patient who is at risk of heart failure, or it's a patient who already received a lot of fluid, then of course you have to be a bit cautious, and you need to infuse this little slower. Okay, so there are certain important things that I need to highlight here. So fluid boluses are beneficial short term, right? So you need to if you need to sort of get them out of the shock state. So that's in that context, the fluid boluses are very useful and beneficial. But then they are harmful in long term. So don't continue to give fluid boluses unless it is really necessary. And there are certain studies where they have shown continue to give fluid boluses has poorer outcome than better outcome. Right. So the caution is because the fluid boluses can cause complications, and these complications are mainly related to neurological system and the respiratory system, mainly respiratory system, which can affect the patient's outcome tremendously. And also, if you are using isotonic crystalloid solutions, they also might cause non-anion gap metabolic acidosis. I explained this earlier. And on top of that, it might cause hemoglobin dilution. Now, remember, all these things we do um, just to maintain good perfusion. Why the patient needs good perfusion? Because patient's tissue needs oxygen and the other nutrients, right? So oxygen is carried by the flow or the cardiac output or the blood flow, but also to remain in the blood circulation, there has to be adequate amount of hemoglobin. So the oxygen delivery depends on the blood flow as well as oxygen content of the blood. Oxygen content is mainly related to the hemoglobin and hemoglobin saturation. So if you are giving too much crystalloids, what will happen is you will have normal numbers, but then because by the way of dilution of the hemoglobin, you might not have uh, adequate oxygen delivery. So normal numbers, but not the desired result. Uh, Other thing that I want to highlight here is the rate and the amount should be tailor-made to your patient, right? So this is very important. This is what I learned as I gain experience as a consultant. Uh, how to deviate from the guidelines, right? So guidelines will tell certain things, but of course you can't apply it to all your patients, and so you should be bold enough to deviate from these guidelines in these situations. But then of course it should be rational, and you should be justify yourself if you are deviating from the common guidelines. And one of the most important thing that we use in critical care is also applicable here. Use sufficient amount of fluid, and remember, better is the enemy of good. So if you are trying to have better numbers, and you might not even have good numbers in the long run. So use sufficient amounts. Right. Okay. So we have now covered the first phase. Now let's see. Let's see what happens to our case. Now you use about 60 per kg fluid, normal saline, isotonic salines, and the parameters improved. And at this point, your nursing officer is asking you to prescribe fluid and ask how much fluid that we use from here onwards. How much and what type of fluid you will use at this stage. Now, this stage is the optimizing stage, if you can remember. Right. So this phase is also called flow phase. And there can be hits during this phase, and this hit is mainly because of the reperfusion injury. Now, earlier hit was mainly because of the ischemia, low flow. But here, main reason for injury is because of the reperfusion route. Now, here the main goal is to maintain organ perfusion by way of using least amount of fluid. So you need to maintain organ perfusion, but you should try to use the least amount of fluid that you can use and avoid complications associated with fluid resuscitation and the fluid infusion. So adequate amount of fluid. And you need to support organ failure. Say, for example, you have resuscitated this child, and now there is pulmonary edema because of the increased amount of extravascular lung water. So, child is tachypnic. So, you need to support this. You need to use it, and you need to give an extra respiratory support to this patient. So, that's how you stabilize that patient. And also, you should be bold enough, as I told you earlier, tailor-made to individual needs. So at this point, you need to think about risks and benefits of further fluid boluses and consider other means of maintaining vital parameters. Say, for example, if the blood pressure is still lower, you need to consider whether to give fluid boluses, further fluid boluses, or whether you should use a vasoactive medication to improve blood pressure instead of giving fluids. Now, this phase goes on for hours, if not for days. Right. So, to understand this phase, it's very this graph is very helpful. This is called Marek-Phillips curve. Now, this curve has incorporated two graphs, and one graph is, I think, a graph that you all know. It's called Frank-Starling curve. This is the graph that depicts the relationship between preload and the stroke volume. And the other graph is the graph depicting extravascular lung water, amount of extravascular lung water in terms of preload. All right. So let's look at the Frank-Starling curve. Now, this is the Frank-Starling curve. You can see that it has a steep curve, steep area, and then plateau area. Now, steep area means if you give a small amount of fluid, there is significant increase in the stroke volume, right? So as it comes to the plateau phase, you can see by increasing the preload, by giving a lot of fluid, you can have very minute increase in the stroke volume, right? So let's relate extravascular lung graph to this Frank-Starling curve. Now, during this steep part, in this steep part, you resuscitate, you give fluid, and there is large increase in the stroke volume. So this part is very beneficial in terms of stroke volume. Now, what about extravascular lung water? Now, when you give fluid, extravascular lung water starts to accumulate, right? So extravascular lung water is the one that leads to pulmonary edema and increase the need to have additional respiratory support. Now, during this initial phase of Frank-Starling curve, now you can say that despite having large preload increment, there is hardly any increment in the extravascular lung water. So during this period, during this phase, it is very prudent to give a lot of fluid. So you can increase the preload, and that will increase the stroke volume. Not only that, that will not increase the extravascular lung water uh, considerably. But once it reaches this plateau phase, it won't increase the stroke volume, but see, it will increase the extravascular lung water tremendously, because now it has reached the steep part of extravascular lung water curve. So plateau phase of the Franz-Starling curve is consistent with or coincides with steep part of the extravascular lung water curve, and the steep part of Franz-Starling curve coincides with the plateau phase of the extravascular lung water. So I think now you can understand, when you can give fluid, when the patient is fluid responsive, you can give fluids without much issues. It won't cause increase in the extravascular lung water that much. But when the patient is fluid non-responsive, further fluid boluses or further increments in the fluid resuscitation phase is not going to help the patient and may even be harmful. So unnecessary fluid administration can lead to undesired effects. So you need to know when to stop. So you need to know uh, what is the point where the patient is no more fluid response. So there are various ways of assessing fluid responsiveness. I said when I became the consultant in the cardiothoracic ICU, this is something I learned. This is something I mastered. But this is not in this lecture, I'm not going to sort of, explain this further. Right. So if you look at this curve, so this is a U-shaped curve. Now we have many U-shaped curves in critical care, and x-axis is the volume status, and y-axis is the complication. Now you can see, if you don't give adequate amount of fluid, if the volume status is lower than necessary, there are complications. The number of complications increases. Now, if you are giving too much fluid, if the volume status increase, again the certain types of complications will go. So you need to find the sweet spot where um, uh, both these complications, under volume hypotensive complications or under volume complications and over volume complications, are minimal. So that is the job. That is the job of a clinician who is managing these patients. So during this period, during this phase, usually you are going for a restrictive fluid administration, tailor-made to the patient. Look at as many parameters as possible, not only the cardiovascular parameters, and in the cardiovascular parameters, not only the pulse volume or the blood pressure or the CVP or whatever, and use vasoactive medications early so that you can spare the amount of fluid that you have to give. Okay, so this is the sweet point where uh, you are giving minimal amount of fluid, right amount of fluid, I would say, which has no over volume fluid overload complications or fluid underload complications. Right. So let's move on to the next phase. So you decided that your child is stabilized, and you do not give further fluid boluses, and you commence adrenaline infusion via a peripheral cannula, and you were informed that a PICU bed is now available, and they ask you to commence maintenance fluid among other things. So what maintenance fluid you will use, how much you are going to use, and at what rate. Right. Now, so we talk about first hit, we talk about second hit, and this phase is also belongs to the second hit. This is called stabilization phase. So the first phase is resuscitation phase. Next phase is the consolidation phase or optimization phase, and this phase is called stabilization phase. This phase will last for days. And goals during this phase, fluid goals during this phase, is to maintain organ perfusion, to optimize electrolytes, to supply nutrition, and also to avoid complications. So during this phase, you will give maintenance fluid, and also you will replace fluid losses, and if there is any deficits, you might think of correcting those deficits. Right. So when we talk about maintenance fluid, you all know this formula. This formula is called Holiday and Sega formula. And at this point, what I want to tell you is that Holiday and Saga formula uh, has been formulated using the data of normal children. So these data actually may not be, this formula may not be suitable for critically ill children that we are managing. So what is the Holiday and Saga formula? It says whenever a child comes, first 10 kilograms needs about 100 mils per kg, next 10 needs about 50 mils per kg, and more than that, for every 20 kgs they need 20, after 20 kgs they need 20 mils per kg. So that's what we call Holiday and Sega formula. So Holiday and Sega formula, actually they arrived this formula using certain assumptions. So the first of the assumption is energy expenditure equals fluid losses. So this is this first 10 100, next 10 50, well, sorry, first 10 100, next 10 50 comes uh, when they evaluated the energy expenditure. So they extrapolated this data into fluids by assuming that energy expenditure equals to fluid. But this is I think all of you know that the energy expenditure in a normal child is quite different from a critically ill child. Then also they thought fluid loss equals fluid requirement. So fluid requirement is given by this. So I'm not going to explain all these things. But what you need to understand is that in critically ill children, energy expenditure is not equal to fluid loss, and insensible loss is more than or lower than usual, because sometimes they are inside the ICU and they get extra amount of fluid through humidification. So insensible loss may not be like in a normal child, and they will have low urine output because of the presence of SIADH. Fluid production may be erratic. So all these formulas will not completely applicable to critically ill children. So therefore, always remember that you might not have to apply Holiday and Sega formula for all your critically ill children. So this may be a starting point, but don't apply this fully in critically ill children. So this means you have to restrict fluid in critically ill children. So don't use the full Holiday Sega formula unless in certain situations, and use oral if possible, because if you are giving oral, it's the body that absorbs the necessary amount, and the fluid composition should contain something like saline, so it should be isotonic, and it should include dextrose if necessary, not always, and it might add other solutions, something like potassium. So I just wanted to highlight potassium because this is something that we do erratically. Now, potassium, when you are giving potassium, potassium cannot be given at a concentration more than 40 millimoles per hour through a peripheral cannula, right? So the maximum potassium concentration that you can give through a peripheral cannula is 40 millimoles per liter. So sometimes what happens is when you add potassium to the existing solution, say for example, you want to give potassium of 2 millimoles per kg per day in a 5 kilo child. So this is 10 millimoles of potassium. When you add this to existing IV fluid of 100 ml, this will have a concentration of about 100 millimoles per liter. So you cannot be give this via a peripheral cannula. And sometimes what happens is you start with the full amount of fluid. So you add the usual amount of potassium, 2 millimoles per kg per day. But once the child starts to get oral, you come down on the amount of IV fluid you are giving. But then what will happen is, if you don't cut down on the, if you don't consider the potassium concentration, or if you don't cut down on the potassium amount that you are giving, the potassium concentration is going to go up gradually once you come down on the amount of IV fluid. So to avoid this situation, it's better to prepare a solution where you have 20 millimoles per liter. Prepare a solution where you add 20 millimoles uh, um, of potassium to 500 ml, which has about 40 millimoles per liter solution, which is the maximum you can use through a peripheral cannula. Uh, so when you are, so if this is the case, then when you are coming down on the IV fluid, there won't be any changes in the concentration. So if you are using a different way, always calculate the potassium concentration. Otherwise, you will have a devastating result. And I have first-hand experience very few weeks ago in our own ICU, where we have given potassium through a very concentrated thing inadvertently, and that is inadvertent, not knowingly. Um, and most important thing here is you need to reassess the fluid requirement frequently. So sometimes you might have to restrict, sometimes you might have to normalize, sometimes you might have to restrict to extreme level. So this has to be done very regularly. So prescribing fluid today morning and then come back the same day evening and next day morning is not going to help the patient. So this needs to be done quite frequently, quite regularly. Right. So let's continue with our case. So the child got admitted to the ICU. You started fluid at a restricted level. Um, but then when you go to the ICU to see this child, this is what you see. A child who appears like a Michelin baby. So child is severely edematous. Child has low urine output. Child is tachypneic with a low saturation. And you look at the chest X-ray. Chest X-ray has bilateral congestion. So what has happened? What you should do? What you should have done to prevent this situation? So let's look at the next slide. So now you have come to what we call evacuation phase. Now this situation has occurred because what we call um, capillary leak syndrome. So whatever you have given is now leaking out. Um, Goal during this period is to have maximum negative fluid balance while ensuring organ perfusion. So in our ICU, we do this quite frequently. But then sometimes what happens is um, uh, we don't allow the negative fluid balance comes. So your goal is to have a maximum amount of negative fluid balance while ensuring the organ perfusion. But then sometimes what happens is you start furosemide, and once you get a good amount of urine output in excess of, let's say, 10 per kg, you chicken out and you cut down on the fluid, curtailing the uh, this evacuation phase. So don't be afraid to have higher urine output during this phase, because you need to get this extra fluid out, this leaky phase out as soon as possible. So this might leads from days to weeks. Few weeks ago, we had a child who stayed with us for about a month, and this child was like this inside the ICU. So it took weeks to get this fluid out, and ultimately we managed to send this child to the post cardiac ward. So why this leak occurs? I think you all have heard about Starling's principle. This is not Starling's uh, law that we discussed in the previous slide, but this is the Starling's principle. So Starling's principle explains the fluid shifts and its physiology. Now this is the blood vessel, and it's the one that has fluid, and fluid might come out and fluid might come in this blood vessel, and the amount of fluid leak out will depend on hydrostatic pressure here, oncotic pressure, and the permeability of these capillaries. So if the hydrostatic pressure increases, if the oncotic pressure decreases, and if the permeability increases, the fluid will leak out. So this is the classic Starling principle. Now at the arterial end, what happens is hydrostatic pressure is high, oncotic pressure is the same, so fluid leaks out. And at the venous end, what happens is hydrostatic pressure is low, oncotic pressure is much more, has a more effect than that. So this fluid that leaks out will enter this vessel again. So this is what Starling explains as having in a normal person. But now we know that this is little different, and we know that now there is thing called glycocalyx in the intraluminal side of the vessels, and these are the ones actually controls the fluid in addition to the hydrostatic pressure, oncotic pressure, um, uh, uh, as explained by the classic Starling's principle. Now, these glycocalyx will determine how much fluid that will leak out. And this fluid will leak out at the arterial end as well as at the venous end. So there is no end, no preferred position for that. And this is the main reason. This injured glycocalyx is the main reason for uh, fluid leak and the capillary permeability in these children. Giving fluid boluses, rapid fluid boluses, an insult like sepsis, surgical trauma, bypass, burns will damage this glycocalyx and increase the chance of having capillary permeability. So once the capillary permeability increases, um, the fluid will leak out and it won't settle until the body repairs this. So this might happen. This might take weeks to months at time. So at the moment, I have a patient who is in private sector, and it's almost 7 days now, but he still leaks a considerable lot. So you have to take that fluid out, and at the same time, you might have to give fluid in because it depletes the intravascular volume. Right. So this is one of the reasons for edema. But then there is another very important thing that might determine edema in these patients. Now, I have two experience in this. One experience occurred when I was a registrar, and we were managing a dengue patient, and as I explained earlier, we were giving a lot of fluid to these dengue patients those days. And when we are giving fluid, uh, so we like today we were maintaining a fluid balance. So this patient was in the E room. I was the registrar, and my consultant asked me, what is the fluid balance? And without thinking, I just read the input output chart, and I said fluid balance is negative 3000, 3 liters. So this is a almost 1 year old child. So there was a negative 3 liters. And then the moment I said there is negative 3 liters, I thought that I'm in trouble. And then he immediately asked, how much fluid you all have given? How come you have got 3 liters out? Only to say that we have given some IV fluids, and the mother also has given equal amount. So this child has received about 4 liters or 4.5 liters of fluid during that short period of time, during that 24 hours. This is a 1 year old child who was probably weighing about 10 kilos. So fortunately, this child had a good kidney which evacuated this fluid spontaneously. So that's why this child not became edematous. So there will be inadvertent fluid administrations, and this is what we call fluid creep. So in the case example that I discussed, that I mentioned, it was the mother who has given some additional fluid. But inside the ICU, inside the ward, there are certain other things which might actually contribute to this extra amount of fluid that usually you don't count in the fluid balance, and this may be very, very significant. And the examples are, if you have arterial line or central line, to flush that, you use certain amount of fluid. And in our ICU, after each blood gas, we give about 3 ml fluid flush. So if you have done about 50 blood gases, which we do in very critically ill children, you have given about 150 extra amount of fluid to the patient. So if you are not actually calculating that might accounted for fluid creep. Now that is my other example. We had about 5 liters total progressive negative balance in one of our post cardiac patients. And cardiac surgeon asked, my God, 5 liters, from where it has come? There must have been some additional fluid which has gone in. So I said initially, no, there is no additional fluid which has gone into this patient. But then he want me to look into it. So we had a very systematic evaluation of the fluid input, and we found that there is a lot of fluid has been gone into through the drugs as drug dilutions, electrolyte corrections, and as flushing volumes. So always know that there is this fluid creep. Now this is this now this study actually looked into the amount of fluid. Now yellow one is the fluid creep. This is the resuscitation fluid. Now you can see that. Uh, so this is the resuscitation fluid. Uh, the orange one. So you can see the difference between the resuscitation fluid and the yellow. Yellow is the fluid creep, inadvertent fluid. So you have given significant amount of fluid which was unaccounted for through fluid creep, but compare the amount that has been given as resuscitation fluid. So always have a way of assessing for fluid creep. Again, the same study on day 1 and day 5. On day 1, you can say that it is the resuscitation fluid that contributes more. So this is resuscitation fluid, that, and the maintenance fluid is the major contribution. But on day 5, you can see that the resuscitation and the maintenance is less, but there is significant contribution from the um, creepy fluid, right? So if your child is edematous and then you don't know why this child is edematous, this is one of the reasons, and then go back and then have a complete analysis or assessment of fluid input of this patient. So your child may be having fluid creep. So this phase is also called de-resuscitation phase. Uh, so I explained most of these things. During this phase, try to use diuretics, but use diuretics judiciously. And if you have a dialysis catheter, try to get fluid out of the dialysis catheter, because furosemide can damage the kidneys. And have a very strict fluid balance. And our goal is to have a negative fluid balance. Remember that. And in terms of negative fluid balance, define goals, what you want, and the targets. And my advice to our medical staff, our staff in our ICU, is to allow fluid to come and closely monitor the perfusion. And if the perfusion permits, get the fluid out as much as possible during a particular time period. To do that, you need to assess them regularly. So you have to be at the bedside. You can't sort of look at the child now and then in the evening and then in the morning. But you need to assess the child regularly to see whether your formula is working or not, and change accordingly. So don't be very strict or rigid on what you have prescribed, but be dynamic. And if this is not working, either go up or go down. Right. So fluid management may look innocent, because that is one of the things that we all can do. And we all do, but it may not be. It may not be that innocent. It can kill children. So, like Hippocrates said, we should not do further harm to our children when they come for our care. So first, do no harm before treating. Don't do any harm. So the child comes harmed by another insult. He don't deserve another harm from our side. Consider fluid as a antibiotic. So like antibiotic, it is being abused. Uh, so, but when you prescribe, if you are a good clinician, you should prescribe antibiotics by questioning these. So, do I need it? So, do the same questioning for fluid. Do you need it? And what sort of thing you need? So, what is the drug in case of antibiotics? So, what is the fluid you want? And what is the dose? So, what is the volume, and what is the duration? What is the rate and the duration of the fluid? And when you don't necessary you stop the antibiotics or you de-escalate the antibiotics. So likewise, uh, de-escalate your fluid therapy. Special situations, just to touch on special situations. In certain situations, I was advocating isotonic fluids up to now, but in certain situations, you might have to use hypotonic fluid. This itself is another lecture, so I don't want to sort of elaborate on this extra vagantly. But in certain situations, you might use hypotonic fluid, and in all these situations, these children has what we call free water deficit. So their sodium levels are high. Sodium levels are high not because we have infused uh, high amount of sodium, but because of the deficit of electrolyte free water. Examples are nephrogenic and cranial diabetes insipidus, where they lose water, and recovery phase of the acute tubular necrosis. And then in certain situations, these are renal free water loss, and there are certain situations where they lose free water extrarenally. Examples are burns and the premature babies who lose uh, uh, electrolyte free water through the skin. Then maintenance fluid in certain situations might differ from what we have preached. Uh, CNS disease, don't restrict fluid then and there. So it is very prudent to start normal maintenance, because in CNS disease, we know that one of the goals of management is to maintain the cerebral perfusion pressure. To have cerebral perfusion pressure, you need good amount of systemic uh, um, um, pressures. So to have that, you need adequate amount of fluid intravascularly. So start with normal maintenance and then titrate. If your child has respiratory illness, they are more prone to get SIADH, as well as they will benefit from reducing extravascular lung water. So always restrict fluid if that is possible in these patients to 2/3 at the start. Heart failure, of course, you restrict to 50% or lower. Nephrotic patients, they have edema, and some of the other patient populations as well, they have peripheral edema. But remember, although they have peripheral edema, they have intravascular depletion. So they need some fluid into the intravascular system as well. So better to start at 80% and then titrate from there. Key points in my lecture. First, do no harm. Better is the enemy of good. So don't go for better numbers. Have the sufficient number. Use balanced solutions if available, if not isotonic fluids. Do not over resuscitate. Reduce the urge to give more and more fluid boluses. Consider microcirculation. Don't just consider macrocirculation. Consider the microcirculation as well. So microcirculation is organ perfusion. And as soon as you finish the first few phases, resuscitation phase, uh, um, uh, other two phases, start evacuation. So start furosemide and get the fluid out as soon as possible. And consider fluid creep in your child, because this may be considerable and may lead to fluid overload. And to do all these things, you need to assess these patients very, very regularly. Very, very regularly. Right. So I'm going to end this lecture with this note. Uh, like this, here in this advertisement, it says one size fits all. So different size of organs, and but this denim trouser has fits all of them. Uh, but in fluid, it is not. So don't think fluid is a thing that fits for all. One size fits for all. No. Thank you very much.
Thank you, Dr. Manjula, for that excellent lecture. So we have few questions from participants.
Yep.
First one, what are the maximum doses of dopamine and dobutamine that can be given from peripheral line?
Difficult question because there are no clear-cut answers. Dobutamine, of course, can be given through a peripheral cannula because it's not a constrictor. It doesn't constrict. So you can use any amount of dobutamine, but we normally don't use dobutamine in excess of 10 because there is no advantage when you use dobutamine in excess of 10. It will lead to other complications like increasing tachycardia. It won't improve cardiac output further. Dopamine up to 10, uh, up to 5 is in dilated dose, so you can use up to 5 without any problems. Up to 10, it has some vasoconstrictor properties, but it's basically it will increase the cardiac output. It will increase the flow rather than constriction. So up to 10, you might use dopamine through peripheries, but in certain cases, until you get the line in, you might use even 10-15 of dopamine through a peripheral cannula. So there are two downsides of using inotropes in the through a peripheral cannula, and that is you might not ensure a good flow. So that is the first thing. And then there can be what we call autoboluses. So sometimes when the child moves his or her hand, it might obstruct the venous flow, and there will be stagnation of the inotropic solutions uh, before the obstruction, and then once he sort of releases his hand, there will be autoboluses, and these autoboluses sometimes can be very very detrimental. So therefore, you can start peripheral uh, inotropes, but you can't persist with peripheral inotropes. You have to sort of get a uh, central line in as soon as possible. Certainly, dobutamine any amount, but as I said, more than 10 is not good. No, it has no advantage. And dopamine up to 10 can be used. And we even use adrenaline up to about zero point 0.1 temporarily through the peripheral cannulas, but very quickly we get uh, a central line in. But in one of my patients, I have used it more than 1 day, and then through a intraosseous because the central venous cannulation was extremely difficult in that patient.
Next question is, how do we decide which vasoactive medication to be used in a particular condition?
All right, so this is outside the fluid lecture, uh, but then because there is a question, I answer it. Now, when we talk about inotropic support, the correct term is vasoactive medication because these medications, inotropy is something that increases the contractility, but these medications, depending on the dose you use, will have different effects. So if you are using higher doses, the predominant effect will be vasoconstriction. If you let's take adrenaline, if you use more than zero point 0.1, it has vasoconstrictor properties, so that's the predominant effect. So it will increase the SVR, but not the cardiac output. So if you take dopamine more than 15, it will have vasoconstrictor properties. Noradrenaline, in our point of view, has usually vasoconstrictor properties. So when you are using these vasoactive medications, first you need to determine what you are going to do, what you want them in. Now, it will depend on the physiology and the issue of your patient. Now let's look at two different scenarios. So we are talking about perfusion, macrocirculation, and the microcirculation. We are talking about perfusion. We are talking about the blood pressure. So let's get the blood pressure so that everyone understands this. So blood pressure has two determinants. One is systemic vascular resistance, and the other thing is cardiac output. So if a particular patient has low blood pressures, it could be because of the vasoplagia, which results in reduction in the systemic vascular resistance, or it could be because of the low cardiac output, or both. Right. Now, when you are starting an inotrope, the type and the dose depends on why you are starting it, what pathophysiology you are going to address, right? So let's take on a septic patient, like in our example. Now, pediatric septic patients can have different hemodynamic patterns. They can have low cardiac output and a higher SVR. So they will have higher SVR, but the cardiac output may be lower. So they can have high SVR and a high low SVR and low cardiac output. So the patient will be kind of having a bounding pulses. And then they can have the other way. They can have high SVR and low cardiac output as well. So depending on the pathophysiology of your patient, you need to think about the particular medication that you're going to give. Now, say a patient comes in cardiogenic shock. Now, what you need to do is to improve the cardiac output. Your blood pressure is low because the patient is in cardiogenic shock. So, why cardiogenic shock? In most of the situations, your left ventricle is not functioning, contractility is lower. So, when you are using an inotrope, what you need to use is something that increases the contractility. But if you use something that increases the systemic vascular resistance in pediatric patients, this is different in adult patients. In pediatric patients, their heart might actually fail further. So you need something that increases the contractility, but that decreases the systemic vascular resistance. So choose of your ionotrope, and the dose depends on these things. So you need, there are few things that you need to study. One is, what are the receptors these inotropes acts on? Beta receptors, alpha receptors. So read around this because I can't explain all these things now. Which receptors and what is the result when these receptors are stimulated, and what dose has what effect. Now, say for example, adrenaline low dose has vasodilator effect and the contractility enhancing effect. So those are the two things. So which will eventually increase the cardiac output. But high dose adrenaline or noradrenaline will have vasoconstrictor properties. So it might increase the blood pressures, increase the systemic vascular resistance, but but on the other hand, it might decrease the cardiac output. It might burden the heart by increasing the SVR. So study the receptors and then study the vasoactive medications in terms of doses and their action. So you will get your answer.
Next question is, what about the acute correction of potassium? Will it be the same, uh, less than 40 millimeters per liter?
Acute correction of potassium is a very tricky thing. Uh, Again, it's another lecture. So there are few things that you need to consider when you are correcting potassium. The first question you need to ask is whether acute correction is necessary in my patient. So very recently, we had a child who had potassium correction, and then child had cardiac arrest because of hyperkalemia, erroneous potassium correction. So very stable child who was supposed to go out of the ICU next day, arrested. We need to resuscitate and has to stay inside the ICU. But fortunately for us, fortunately for the child, fortunately for the parents, there were no CNS insults. So in this child, when we evaluated, we found a lot of uh, miss issues, lot of issues of giving potassium. And one of the issues that we found was there wasn't any necessity in this child to use intravenous potassium correction. Right. So the first question you need to ask is whether you need to correct potassium. Second question you need to ask is what sort of route or what sort of potassium correction method that you use. That all depends on the situation and the stability of your patient. Say for example, you have a child who has ileus abdominal distension and you need optimum potassium. of course, and your potassium is somewhere around, let's say 1.8. Of course, you need intravenous potassium correction in this child. And then there will another child, post-op cardiac child, very stable, and we have given the goal of potassium correction as 4.5. So this child has 3.9 potassium. There is no need to correct it intravenously. You can either not correct it, or you can use different methods of potassium correction, right? So potassium correction. Second question is whether the potassium correction. What is the modality? What is the way of potassium correction? So there are certain ways of potassium correction, and the most low risk way of potassium correction is to use potassium sparing diuretics and avoid having hypokalemia, because that occurs as a result of diuretics. So in our ICU, we use diuretics a lot, and as a result, you get hypokalemia time to time. And one of the ways of avoiding this is using optimum doses of uh, spironolactone or any other potassium sparing diuretics. Secondly, using oral potassium to correct potassium deficits in very stable, otherwise good patients. Right? We use now there are different formulas, and at the moment we use IV formula. We use 1 millimoles per kg uh, to correct potassium in these patients. And if the gut is functioning, usually you can see within about half an hour the evidence of potassium correction. You can repeat it. You can repeat it again and again. And in other countries, they have what we call effervescent formula. So it's called clovacin. It has a very high absorbent rate. So you give it, it absorbed very quickly. It's like Disprin. So it dilutes very quickly. Our potassium tablet, it absorbs, but it's very difficult to dilute. So if you have a patient who can take oral, you can give potassium tablet to correct potassium. But if your child is ventilated, and then if you are giving it through the NG, then of course you need to dilute it, and these tablets are very hard to dilute. So that's why we are using IV fluid. So second modality is using oral potassium. But if the gut is not functioning, and if you need to get the potassium up very, very quickly, then of course you need to use IV potassium correction. There are different ways of using it. There is a formula to get the potassium deficit, and you can administer it. But we are actually in the process of changing this, because most other countries has changed this. They are not using this potassium formula, but they are using what we call potassium concentrated potassium solution for this.
Then there is a request to arrange a separate lecture on patients with lung, heart, and kidney disease in relation to fluid management, as well as a request to share the lecture note. So the recording will be available.
Yeah, of course, I have put the lecture notes into your computer here. So I think the participants can request from the Shri office. And other lectures, I'm happy to do other lectures if there is necessity. So I think the organizers can discuss with me about those.
Yeah, thank you. And yeah, the Shri team will arrange it in the meantime. And again, thank you very much for your excellent lecture and precious time, Dr. Manjula Hewageegana, intensivist at Pediatric Cardiothoracic ICU, Ledridge Hospital.
Thank you very much. Have a great time.
And dear participants, please find the link in the chat box and answer the post assessment question and fill the link and get your feedback, and you can receive the e-certificate for participation. Thank you, everyone.